Hi everybody, Dr. Deed Harrison here of Chiropractic BioPhysics Seminars and Technique and Chiropractic BioPhysics Nonprofit, our spine research foundation. If you've been following these video reviews on the Chiropractic BioPhysics YouTube channel, you know I'm covering each one of our CBP nonprofit peer-reviewed publications in a video presentation format. This just simply saves you from having to download the full text, and I know that many of you don't actually do that. In fact, most chiropractors and medical doctors and physical therapists, they just don't take the time to actually read the full text. So what I've been doing is going through our research publications in a simple video review format. This week, I'm going to cover one of my personal favorite topics. This addresses a critical concept in chiropractic radiology. In fact, it's not found anywhere in medical radiology. It's only in the chiropractic radiology literature. It has to do with the hypothesis that changes in the architecture of the cervical articular pillars or the facet processes will affect the cervical lordosis. So this particular project is actually one of my personal favorites. We did this in 2005 in the journal Clinical Anatomy. The title of the paper is Do Sagittal Plane Anatomical Variations, aka Angulation and Height of the Cervical Facets and changes in the shape of the C2 or odontoid process in the sagittal plane, do those affect the cervical lordosis? And this was Clinical Anatomy, volume 18, pages 104 through 111, 2005. Myself, I'm the lead author. My late father, Dr. Don Harrison, my great friend and CBP instructor, researcher out of Colorado, Jason Haas, and then PhD, Dr. Tad Yannick, my father's former PhD advisor and professor, good friend of ours and the family, and then the late Dr. Bert Holland. Again, this was in Clinical Anatomy, which is really a very high-end journal. It's put out by the Mayo Clinic. To begin, let's do a little background. Number one, as I said earlier, this topic is only found in the chiropractic radiology literature of interest. Now, it's not that chiropractors can't come up with something unique. The problem is if we see something that's only specifically found in radiology in one profession, you got to start to question it. Why has it never, ever been reported in the medical radiology literature of interest? So in the 1970s, a chiropractor and really a chiropractic radiologist by the name of McCray from Canada put out a self-published book with no references in the entire textbook, no references, only hand-drawn photos. I grabbed the textbook from Life Chiropractic College West, where I went to school as a student in 1995, and I looked at this book. Not a single reference in the entire book, right? Not a single image of a true X-ray, hand-drawn photos of this. McCray claimed the following thing. He claimed that architectural changes in the facets and the pedicles will create hypolordosis, or straightening of the cervical curve, and or kyphotic, or reversal of the cervical curve. A is the normal appearance of the articular process in the cervical spine. This is the vertebral body, so the front aspect of the vertebra. This is the superior facet surface. This is the inferior facet surface. And then this would be the vertical height of the articular pillar. We can get an angle of these facets in the sagittal plane by drawing a line along the superior surface and the inferior surface, and we can look at the way those surfaces either converge or diverge, or if they're parallel. Now B represents what McCray called hyperplasia, or enlarged pillars. You can see that the height of the articular pillar is very tall. Okay, and then oppositely, C represents what's called a hypoplastic, or smaller pillar. Now, I'm going to stop right here. I read McCray's book, and right away I became skeptical because I looked at B and C, which are exact opposites of each other, but yet McCray said they caused the same thing. They both cause straightening of the cervical curve. And I thought, wait a minute. If one causes straightening, the other would cause an increase. That would be common sense, right? Well, so right away I was like, this is a red flag. I'm going to investigate this when I graduate and have the opportunity to do so on real patients. D, D shows an acute angle of the lower surface of the facet surface compared to what's shown in A, and then E represents what would be called short pedicles. So short pedicles mean that the pedicle here, the transverse, basically circular tubular structure that separates the vertebral body from the articular pillar here, is shorter, so the pillars overlap with the vertebral body. So McCray said long and short pedicles both straighten out the cervical curve, and I thought, well, if short pedicles straighten it out, then long pedicles would increase it, right? They would do opposites. Anyway, that was the original history of this. It traces back to, as far as I know, McCray. Further, there was a study in 1987 in the Journal of Chiropractic that came out that perpetuated this concept. It wasn't actually a formal trial or correlation study on this. It was just presenting the same kind of opinion, no real statistical data, etc. This came out in the late 1987 or late 1980s by Peterson and Way, both chiropractors, and of interest, Way is a chiropractic radiologist. They said that in this particular case study, vertical hyperplasia of the articular pillars were responsible for straightening of the cervical curve. Now, you don't really know that in the person. You don't know that in the patient. Just because you have a patient with this and they happen to have, consequently, a loss of the cervical curve does not mean that one caused the other. You cannot identify that from a single case report. Okay? So then further, later in JMPT, the Journal of Manipulative and Physiological Therapeutics, 1999, came the first attempt, I say attempt because this particular study had many problems in my opinion. And my group actually wrote a letter to the editor, and maybe I'll do that letter to the editor in a different video review maybe next week. But Peterson et al. Put this out in JMPT in the late 1990s, looking at 48 neutral lateral cervical curves and attempted to look at articular pillar hyperplasia as it related to the cervical curve. The study has several problems. Number one, the sample size is rather small to look at this. Number two, they did not assess segmental angles of the cervical curve. They only assessed the total angle of cervical curve. And then one of the measurements they used is not even a measurement of cervical curvature. It's really a millimetric depth, if you will, of the distance of the cervical curve from a straight line to the apex of the curve, which is very problematic when you look at, is that really actually an angle of cervical spine curvature? The answer is really no. So this particular study had several problems. It also had statistical analysis problems, etc. We might do that in a letter to the editor. At this time, however, this was the only report ever done to truly look at, is there a correlation between changes in articular pillar architecture and alterations in the cervical curve. They concluded that articular pillar hyperplasia is common, and accepted normal values of a lordosis need to be reassessed based on articular pillar configuration, okay, based on their particular study design and what they identified. Well, aside from the letter to the editor, if we look at this, we go, well, that one paper suggests that if there is indeed a correlation between change in cervical articular pillar architecture that affects the amount of cervical curve, then practitioners and techniques like chiropractic biophysics, we need to actually be aware of that, because before we say a patient truly has an abnormal cervical curvature, we would have to see, is it driven by changes in the cervical pillar architecture or the facet angles? If it was, then we'd have to come up with a way to assess that in every patient and see, are they fitting their anatomy, or do they have an alteration in the curve based on the alteration in their anatomy? So we would have to do some background work as a clinician before we decided, to pursue rehabilitation of the cervical curve with a given patient. This would create a big challenge for us. Now, it's not that we're afraid of that challenge. We'll take that on. If there really is a relationship, a true correlation between loss of the curve at the segmental level and change in cervical pillar architecture, then I'm going to figure out how to account for it, right? So because of the problem in the literature, because of the issue, there was only one actual paper with a limited sample of 48 subjects, poorly done in terms of measurement and poorly done in terms of statistical analysis, and then the rest of the studies are just opinion pieces put out by authors with no data. I looked at this and I said, you know what, we need to do a proper correlation study with a large enough sample size to see, is there a correlation between these two variables? On the one hand, cervical pillar architecture and facet angle, and on the other hand, cervical curvature. Okay? In this project, we also decided to look at the shape of the dens. Since we're looking at sagittal plane alterations in anatomy, there are some authors in the literature that have suggested, with no data, that the change in the angle of the C2 dens, so the odontoid process, versus the back of the vertebral body of C2. Some denses are lordotic tilted, some are straight, some are kyphotic relative to the back of the C2 vertebral body. Some authors have claimed that that will affect the cervical curvature. And you can see the references in here, 1973, 79, and then 1998. By the way, there was no data for this. So I decided, well, let's look at this as well. Okay? So here's the concept with the odontoid process. For example, in A, this is considered a kyphotic odontoid process relative to the back of the vertebral body. You can see the dens bends forward anteriorly towards the face. This dens, the back of the dens, odontoid process, is pretty straight with the back of the body of C2, so that would be a straight one. And then this dens is lordotic. So we can see that the dens odontoid process relative to the back of the vertebral body is lordotic. Now these are the three things we're going to assess, and we'll look at a measurement for that. Of interest, just right away, you can notice that this kyphotic dens, this straight dens, and this lordotic dens don't really appear to have a relationship to the type of cervical curve, at least in the examples that I've shown, but we need a larger sample size to look at that. So this particular study, what we're going to do is we're going to do a retrospective look at 252 consecutive lateral cervicals. Now what we needed is we needed neck pain subjects that were not acute neck pain, so we didn't want the idea of spasms in the cervical spine, etc. And we didn't want extreme degenerative changes in the cervical spine. And we had to clearly visualize the structures. That was our only inclusion criteria. So we had to be able to clearly assess the skull down to C7 vertebral body. We had to see the facet joints, etc. We had to see the dens. So we had neck pain scores, neck disability index on all these subjects, examinations, etc. And we had to clearly visualize all the structures. Then we digitized the lateral cervical using a sonic digitizer to touch points and put the two-dimensional coordinates into a computer system. That computer system, then we assessed multiple measurement variables. The total angle of cervical curve from C1 to C7, the total angle of curve from C2 to C7, and then all the segmental angles of curvature from C2 to C7. We also looked at the vertical height of the articular pillar. We normalized that height relative to the height of the vertebral body. So not just the overall height of the articular pillar, but we normalized it to its corresponding vertebral body to see, is it too big, is it too small, is it within normal limits, etc. We looked at the angle of facet surfaces. Are they parallel? Do they converge posteriorly, or do they converge anteriorly? We looked at the shape of the dens in the sagittal plane as well relative to the vertebral body. Then we statistically analyzed these appropriately using scatterplots and proper correlation coefficients using the Pearson R. We sought to identify, is there any relationship between facet heights, facet height normalized to its vertebral body, facet angles, and the odontoid process in the sagittal plane relative to total angles of curvature, meaning ARA, absolute rotation angle, and RRAs, meaning relative rotation angles or segmental angles of curves. We used both Cobb angles and Harrison posterior body methods. Now, why are segmental angles the most important here? This is the biggest part of the study, in my opinion, in addition to the sample size and proper statistical analysis. Well, if you have a change in the vertebral architecture of the articular pillar at the level, it's going to affect the curve at that level. It's not going to affect the curve above and below that. It's going to affect it at that segmental level. That's the obvious, common sense approach. Nobody has looked at it up until this point. So here's the idea. We're going to look at, do these facet surfaces converge posteriorly or are they parallel? Now I do want to throw out this. In my opinion, and in the author's opinion of this study that we're talking about, we believe it's naive, in fact very naive, to believe that a sagittal plane assessment on the facets can accurately assess the slope of this curvature. If you look at the surface of the facet joint, it is actually very sloped oblique, and it has almost a semicircular type of angle to it. Depending on what point you're looking at, the angles can change. So is this truly an angle that represents the slope of the facets, or is it only on the lateral margin of the facet do these angles actually represent the slope of the facet? So, let's look at the structure 3D. This is what you get in a true 3D analysis. Does this angle really represent it? And the answer is no. It's rather naive to believe that these facet lines truly represent the oblique surfaces of these articular processes. It's likely more relevant to look at the height of the articular pillar, which we did in this particular study that nobody else actually did. So just as an example, here's a kyphotic dens. Here's convergent facet lines at C4, and then here's divergent facet lines at C6. So you can see at different levels in the same X-ray, you can have different shaped facet surfaces. Now, do they correlate to the segmental angle of curve at those levels, and do they correlate to the total angle of curve? That remains to be answered in this particular project. And then here's how we assess the slope of the dens, if you will, or the angle of the dens. We put a line on the back of the body of C2 and the line on the back of the body of back of the posterior surface of the dens. And we just looked, is that angle lordotic, is it straight, or is it kyphotic? So scatterplots. Scatterplots are really the best way to initially screen for correlation between two variables, right? So what I'll do is I'll take my dependent variable and we put it on the y-axis, and we take our independent variable and we put it on the x-axis, and we plot these two variables in relationship to each other. Now in a scatter plot, if I see something that looks like a swarm of bees, there's just really no obvious correlation. But if I see that there is a correlation, I can draw a best fit line between those, and I can look at a slope and then look at its correlation coefficient. Then I go, hey, there's either a positive slope if it increases this way, or there's a negative slope if it increases this way. So either they are directly linearly correlated or they're inversely correlated. In other words, a positive slope would be as one gets bigger, the other one gets bigger. A negative slope or negative correlation would be as one gets bigger, the other one gets smaller. So that just shows us here. And the greater the ratio of these correlations are to 1, the more true linearly these two things are related. So we're just going to look at some correlations coming up. Now, here's our table of correlations between variables. Now, if I look here, Cobb angle C1 to C7, that's the total angle of curve, C1 to C7 using a Cobb angle. There are some correlations that are statistically significant, but they're correlated to other angles of curvature. That makes sense. So my cervical curve is correlated to segmental angles of curvature. Well, no kidding, because the segmental angles give rise to the total angle of curve. So we expect some of those things to be identified. That's just testing, is our data legitimate, in my opinion. C2 to C7, ARA, posterior body angle of curvature, is it correlated to the Cobb angle? Well, yeah, it's really strongly correlated, 0.7 and 0.8. That's approaching 1.0. So these would be considered good to excellent correlations. That means the cervical curve with one method is correlated to the cervical curve with another method, etc. When I start to look at, is there correlations between these variables and facet angles, the only thing that I really see is facet angle 4 is correlated to relative rotation angle 4, but it's very weak. So this is facet angle, the slope of the inferior and superior surface of C4 facet, is it correlated to a segmental angle at C4? weakly correlated. The other ones, they're not correlated at all. So facet angles are not correlated. In fact, this is the only weak correlation we found. It was C4 facet to C4 relative rotation angle. None of the other variables were correlated whatsoever at all. Just to give you an example, here's a scatter plot. This is the ARA C2 to C7, looking at the angle of curve from C2 to C7 posterior body relative to the Cobb angle C2 to C7. You can see that these have a positive slope. Of course, these two measurements are attempting to measure the same thing with a slight difference in how they're approached, so these should be correlated. And again, this had a correlation that was in the 0.7s. This is Atlas plane line and the amount of head translation. There's a weak correlation here. In other words, the further you stick your head forward, there is a change in the Atlas plane line to horizontal. That makes sense. We know that. And then here's Atlas plane line relative to the total angle of curve. There's actually no correlation between the Atlas plane line relative to horizontal and the total angle of curve from C2 to C7. Of interest, those two curves kind of behave differently, or those two angles behave differently. Here's the breadth of what we looked at. We looked at many correlation scatter plots, and the only thing we found that was weakly correlated was facet angle 4 to facet to relative rotation angle at C4, C5. The other ones, you can just see these are not correlated at all, and I'll blow up a couple. Here's the ARA C2 to C7 total angle of curve relative to the facet angle at C3. There's no correlation whatsoever. Here's the facet angle at 4 compared to its relative rotation angle at C4. This is weak. It's very weak. In fact, it's probably just a random chance occurrence. You can barely see any type of linear correlation. It came out 0.24. It's weak. Nothing to write home about. Conclusion. We found no statistical correlation with hyperplasia of the cervical facets in any angle of cervical curve, except there was a weak correlation at the C4. No correlation between the vertical height of the articular pillar and the cervical facets in any angle of cervical curve. Our study was the first to truly look at this. We found no correlation. Also, no correlation between the shape of the dens in the sagittal plane and any angle of cervical curve. Our study findings refute the hypothesis that anatomical architectural variants of the facets and dens have a relationship to the cervical curve. Thus, surgical and rehabilitation methods that attempt to restore the cervical curve in patients that don't have one do not need to consider the cervical articular pillar angles, heights, nor the C2 odontoid architecture. Okay? This is a very important issue. This study is the largest sample to be ever to be done on this project, or on this idea. We found there's no relationship whatsoever between the cervical curve and the change in articular pillar architecture and angles, minus a weak correlation at the C4 level. Okay? There's no correlation between C2 and the slope of the dens in the sagittal plane and the cervical curve. What does this mean? It means that the chiropractic opinion in chiropractic radiology that changes in the cervical articular pillar architecture have a relationship to the cervical curve. It means that it's made up nonsense. It's just total made up nonsense. Minus the one paper in JMPT in 1999 that was poorly done. If you actually read it and look at it, there's no evidence to support that idea. Chiropractors that do corrective care work do not need to assess the articular pillars in their height, in their angle, relative to the cervical curve. Now, conversely, if we would have found that there was a relationship, my group and I, my team and I, we would have come up with a model to look at how this truly affects the cervical curvature, and then we would have had to come up with how to account for it in a patient. We would have done it. I'm telling you, we would have done it. But the thing is, we first have to test whether or not it even matters. And we identified it doesn't even matter. 2005. Still today, 12 years later, This kind of stuff is still taught in certain chiropractic radiology circles, that articular pillar architecture changes the cervical curve. It's still taught. Nobody even reads the paper that we did in 2005. So I'm doing this video to go, shame on you guys. Let's update our concepts. Let's update this. Let's give it a fair look. If you're going to claim that articular pillar architecture affects the cervical curve, you better reference the best paper ever done on the topic, and that was by my group and I. Maybe later on there'll be another paper that comes out that refutes our results. I'm happy to look at it and I'll happily reconsider. But as far as I'm concerned, this issue has been addressed and put to the table. Thank you for your time and attention. I'm Dr. Deed Harrison.